bit of a long one, this one. Neuro assessment with my buddy Aidan the physio.
Alrighty, so Aidan, what I think, if I talk you through what I think is the neuroanatomy of the lower limb as I understand it. So we'll go on the outside just because that's where our foot model is. Sural nerve comes around at the back of the lateral malleolus, and if I'm teaching my students, what I'll say is if you look at the lateral malleolus and the kind of the point of the heel, if you do a line between the two and bisect it, it's always in that top half and it's subacute. So it's primarily a cutaneous nerve at my level of interest, which is here, and it's a combination nerve. It comes a little bit off the common perineal and a little bit off the posterior tib, so it's a combined nerve. Comes down and supplies the lateral foot. Now there's actually, if you look in the book, and have you come across an anatomy book called Seraphian? It's for anatomy nerds like me.
I think you've told me about it before, yes.
Most amazing book. And they'll talk about these 5 different nerve distribution patterns for just the sural nerve. So 2 common, 3 less common. But I think of it as being plus or minus little toe, because sometimes that'll be the top nerve, sometimes it'll stop short, sometimes it goes all the way under across 2, occasionally 3, 4, would you believe it goes as far plantarly as that. But the sural nerve's coming around on the side. Really unusual for me to see a sural nerve entrapment in terms of an idiopathic one. That said, I had one 2 weeks ago, had a lady come through and she had some pain there, so it was neuralgic pain on the side of the foot. No history, no background to it. Popped some cortisone in and she was back a few weeks later all pain-free, and she's really pleased. And I've seen 2 this year, but I hadn't seen one for 5 years before that. So that's really unusual. And typically when you see it, in fact, really, to be fair, the nerve, I've drawn that badly, it's actually coming round at the back there. So normally when we see sural nerve issues, it's normally because some patients had some gastroc irritation. So most of the ones I've seen have been post-gastroc surgery where the nerve gets caught within the gastroc surgical scar. And one of the variants, it can be within the paratenon. So once or twice I've gone into the paratenon of the Achilles and the nerve's been there. So fairly unusual. Sorry I marked that one up badly. That's because I've had a long day. Just coming around, Grace, if you just kind of rotate it just out a little bit so the camera's picking that up. So this one's also relatively unusual, but believe it or not, I've seen one this week. So the superficial perineal nerve, in terms of a local entrapment, that's what I see in the foot a lot, but it's uncommon. The superficial perineal nerve, known in the foot as Henry's mononeuritis.
Okay.
Superficial perineal nerve, classically, deep to the muscles, comes off the common perineal, where it's, common perineal coming around the ankle, around the head of the fibula, splits into deep and superficial. Superficial pierces the fascia, the lower third of the leg, typically. And it comes out as either 1 or 2 branches. So you've got variance there. Occasionally it comes out here, but it's normally here, 1 or 2 branches. Supplies all the top of the foot, except sometimes little toe, and except here we'll come to it. So this is our Henry's mononeuritis, and would typically come on either ankle inversion sprain, which is the guy I had this week. So he was literally sore, you could roll the nerve underneath your finger and you could actually get that tinels going down into your foot.
Yeah.
But I don't see many. And you come through with an ankle inversion sprain, so you look at ATFL was fine, you look at sinus tarsi was fine, and actually he was Henry's. So it can be with an ankle sprain, or it can be if you've done ankle surgery. Classically, the most common times I've seen it is the lateral portal for an ankle scope. It just catches that lateral branch. Supplies all the top of the foot, and say splits into these 2 branches. Coming around, Grace, if you just kind of rotate. Now this is that looking okay in the video there?
Yeah, you can see that, okay.
Yeah. Deep perineal nerve, called the deep perineal nerve because it's deep to the deep fascia, only pierces the skin about this point here, so it becomes cutaneous here. Very common to get irritated with dorsal midfoot arthritis over this joint here. So this is the second tarsal metatarsal joint, and I see this arthritic every day. I've seen 2 today, and I've only had a half day today. Very often they will see arthritis here, and quite commonly irritates the nerve. Bump below, shoe above, and the nerve gets pinched. So in the foot, this is known as anterior tarsal tunnel syndrome. Have we mentioned to Grace that this pen doesn't come off for that? It can be removed with Brillo pad or fire. Otherwise, it's going to be there until later in the year. Never mind, it's fine. It's fine. It's for science reasons, all right?
Worth it.
I was running a cadaver lab a couple of weeks ago in Scotland, so people leave their whole bodies to science. This is just scary.
Small portion.
I've been on holiday, it's fine.
So I often see that interact with second TMT arthritis, and you'll get a real Tinel's in that, really kind of radiating down into the toes. So you'll often get a Tinel's there, but the pain will often course distally. This I'm a big fan of doing cortisone shots for, but occasionally I have to kind of decompress the nerve. Orbicus cutaneous there, and as you know, it actually supplies the big toe, but it also branches to the sinus tarsi. And then, how can we see the saphenous? Shall we move the camera around? Good job. So on the medial side of the foot, we've got the saphenous vein, and medial to the saphenous vein, we've got the saphenous nerve. And effectively, it's doing a 2-inch strip all the way down the inside leg. It's the only nerve in the foot that's not coming off the sciatic. This one's coming off the femoral and supplies this kind of 2-inch strip. Again, plus or minus big toe, there's some variance there. I've never seen that as an entrapment neuropathy, which I was saying just before we click play. 4 times out of 5, if I see a neuro case, it's a local entrapment neuropathy. I've seen a diabetic ulcer today, neuropathic ulcer. I saw a Henry's this week, and I saw an anterior tarsal tunnel. Typically, it would be an entrapment neuropathy rather than something more proximal, which is just as well because I'm only insured to about. So the only times I've seen this entrapped is when people have had a cabbage and they've had the saphenous vein harvested for the coronary artery bypass graft, and that's super rare. It basically just causes numbness here. Now the one I see very commonly, but it's underdiagnosed, is tarsal tunnel syndrome. So we've got, you're still in shot there.
Yes, yeah.
So posterior tibial nerve, PTN, comes around, and you've got your flexor retinacula here. That's what keeps all the gubbins in place. And it is tib post, flexor digital longus, then it's vein, artery, vein, nerve, and then hallucis longus, the most lateral. So you've got your artery coming down, the nerve is right on it, comes down. The first branch off, splits quite high, is this medial calcaneal nerve and supplies the plantar medial skin of the heel. Rarely do you see that as a nerve entrapment on its own. I see a handful a year, and I see heel pain every day. What you'll see a lot with your fasciitis patients, we know fasciitis very well, is that we'll see some neural involvement with a plantar fasciitis, and that's because the medial branch, the medial band of the plantar fascia, which overlies this muscle belly here, abductor hallucis, you will often see pressure in this, putting some extra pressure in that posterior medial compartment. So your nerve splits down, first branch off, and then medial lateral plantar nerve. So we'll see quite a lot of distal tarsal tunnel, which is here, underneath our abductor hallucis muscle belly here. And I'll often see local tenderness there. Now I would call, when you press on a nerve and it's locally tender, that for me is Valix phenomenon, V-A-L-L-E-I-X.
Yeah.
You happy with that? Would you agree with that?
Yes, yeah.
Okay. Don't find it Tinel's, because that's quite a long way in. It's 3/4 of an inch in, where the nerve is underneath this muscle belly here.
I was going to say, where you're pointing here is, I think, the general sort of teaching of nerve entrapment tarsal is malleolus, slightly out to the side from there, and then you do Tinel's, and you think that is where you generally get taught.
Really?
So actually going more distally is interesting.
Yeah, 80% of the time it's here.
Okay.
And I published on this because I've had a little look at it. You can get it underneath the flexor retinaculum for sure, and you might get a Tinel's, but I don't find it here. Valix here, local soreness. Or Tinel's, Hoffman's.
Yes.
Do you know they both rotated in the same year?
Did they?
Yeah,
Okay.
different sides of World War One, so it's now Tinel Hoffman's in neurology nerd. So I rarely see tarsal tunnel up here, nearly always distal. And then if you can isolate, there's 2 issues we might see here. So rarely where we'll see medial plantar nerve underneath the muscle belly, distally, really, really distally, just irritation, just the medial plantar nerve, that's known as jogger's heel.
Okay.
You can cross that one.
Not jogger's heel, no.
So that's just the medial plantar nerve.
Okay.
but it's very difficult to differentiate from the knot of Henry, where flexor lucis and flexor digitorum longus cross over, which is about the same sort of area. The two tendons cross over, share a few fibres, and you can get some tendonitis between those two conjoined tendons. So they can be very difficult to separate, and that will be, again, I'll see a handful of those a year, literally can count on one hand. Plantar fasciitis I see every day, multiple times a day. 10-20% of the time, there's some distal tarsal tunnel. Medial calcaneal nerve is rare because it becomes superficial so quickly, and these ones are rare as well. And so I've got a fairly low index of suspicion for looking at nerve entrapments because I see them all the time. But clearly, if you've got patients who've got multiple levels of nerve entrapment, it tends to just be one bony bump, then I'm looking more proximally. Every podiatrist in the world I know, bar about 3, are either not very good or not very confident at neuro assessment. And I know, having run a neuro course a few months ago, and I used to teach it in my academic days, it's difficult. So I think we can teach pods how to do a neurological examination. We need to think as well about central nervous system issues, peripheral nervous system, sensory, and then motor findings, and then autonomic as well. What I think is still difficult for me as even a jobbing surgeon is to say, unless it's an obvious entrapment, which I think I'm good at getting, how do you get neurological symptoms meeting with a more classic diagnosis? So, for instance, I had a guy in a few weeks ago. I've got a little video I'll show you of. So he had a bit of a kind of a wobbly, bendy big toe, and you look at the foot and you go, that's a neuro foot. A little bit of retraction, a little bit of extensor substitution. Did some testing, left foot for right, left foot completely normal, all straight toes, right foot, some retraction, extension, substitution. And he was weak in all 3 extensors, tib, anti, HL, EDL. Normal sensory, weak motor.
Okay.
Sent him for spine MRI through his GP, who haven't had the results of this yet. So I can say his sensation is fine, neurologically is fine. He supports Liverpool, so clearly there is some neurological involvement. Or socially, we don't judge, of course, but a little bit we judge. But we found some motor weakness. Why is that? Is it something within that dermatome? Is it something here? Or is it something more proximal? Or is it something really proximal up in the brain? And that's where I go, And what I try and teach my guys is you won't always get a diagnosis, but it's about finding, when you're testing at whatever level, something that's not quite normal, finding the foot at risk as a pod, and then referring on to the right person.
Yeah.
So every month I refer on for either spine MRI or I refer to the neurologist. We've got the guy here, he's a good neuro, and I go, look, something's not quite right here, can you check this out? And it might be that there's a foot pain, pathology, whatever, but it might be it's not within my sphere of influence, shall we say. Does that make sense?
Absolutely. Could you talk about Baxter's nerve entrapment as well?
Oh, I can.
Slightly.
Yeah,
You mentioned plantar fascia, and I think we've had a discussion before where it's one of those ones which is considered a differential, but if you could touch on that, that'd be great.
So the lateral plantar nerve is coming down there. Sorry we haven't got more pens, but that's just it. Medial plantar nerve comes there. So Baxter's nerve is the first branch of the lateral plantar nerve. Again, there's some variability in where that comes off. It can come off quite high. And it's going to supply the plantar-lateral musculature, so quadratus plantar, flexor minimi, abductor minimi, brevis. So it's supplying 3 muscles on the plantar-lateral aspect of the foot. There are 2 places it can be entrapped, but I've only ever seen it in one location trapped, and that's with a heel spur. So you and I know that heel spur is a really common radiological finding. 50% of the normal population have a heel spur. But in a heel pain population, it's 50 to 75%. So a heel spur is part of the pathology of plantar fasciitis. It's more, I think, a compressive force rather than a traction force, which is what I was taught before you two were born, that it was a traction of the plantar fascia. So where you see a heel spur forms is right where the Baxter's nerve goes. So every time I've seen Baxter's nerve problems, we've done an X-ray, there's a heel spur.
Okay.
And what that creates is plantar lateral neuralgic pain. So valix again, because you can't tunnel as it's too far in, and you get sharp shooting plantar lateral pain. and there's always a heel spur. Can get caught underneath here, classically, under abductor lucis. I've never seen it. It's in the books. And it does actually, I'm a big fan of injections, as you know, but it actually responds quite well to a deep injection to hydrodissect the tissue and the nerve away from the spur. But it's there as your Baxter's. But it's neuralgic pain. It's not that searing pain that you get with fasciitis, but of course you have both. And it tends not to be the first step pain that you get with your fasciitis. Policeman's heel. You're happy that policeman's heel is not the same thing as fasciitis?
Yes.
So policeman's heel is your plantar calcaneal bursitis, which is more central. And you typically see that the person that's standing a lot, relatively thin heel pad. Radiologists will often struggle to differentiate between the two, but it's central and more posterior, and you're right on the tubercles of the calf.
And is that local, or can that refer? So it's
No, that's local.
Local to the
That's local boning.
central.
But you can have other issues going on as well. So that's a very much, you press on it and it's out, and you can just feel basically your skin and bone. And I've got a few slides where you've actually got a true adventitial bursal formation. But they're a little bit of a way. But again, you can get mixed things. You can get true. I've got a guy saw Thursday of last week. He's got the both.
Okay.
Usually it's plantar fascia. That one is 1 out of 20. That's much less common. But I've got a lot of heel pages on the go at the moment. And then super rare, but I saw one yesterday. Lateral plantar fasciitis. 1 in 20 the lateral band. It's normally not. But I had a guy in, just had his MRI, really thick there, but inflamed, and it shows up high in an MRI. So I'm going to do plantar lateral, but I get just a small number of those a year. So I'm kind of like anatomy nerd, knowing where all the kind of the stuff is. And it's kind of difficult to pick up, I think, all these little subtle bits from just a centimetre this way is a different diagnosis. Where I struggle with, genuinely, is then putting dermatomes on that. So you get a patient that's got a classic, one spinal segment that's pinched, and then that gives you issues within that dermatome. Because obviously all these cutaneous nerves, they're all blended nerves.
Yeah.
That's different from the dermatome, which is why I need somebody clever like you to tell me where the dermatomes are and what I'm doing wrong.
Let's do that. Dermatomal wise, cutaneous layer of the skin supplied by the nerve roots from the spine. We've obviously got upper limb, lower limb, and then that thoracic region, which we know thoracic regions can be enlightened by sort of shingles and that sort of stuff. But lower limb initially, say we've marked race up ever so slightly with the rough patterns. And I say rough patterns because we discussed before, and I've been on a couple of courses. I've had a read through some of the research papers, and the patterns you see are usually classic ones. So Forrester in 33 and Garrett and Keegan in 48. So very sort of old school, very sort of potentially out of date as such because of the testing wise. Some of the levels they didn't test, but it's good to have a bit of a reference point, and that's what I use it for purely in my clinic. A reference point of the dermatome patterns. Is there pain? Is there numbness? Is there tingling, burning, that stuff? And if I can link it up to a nerve compression, nerve irritation from the spine, I use that alongside things like myotomes, look at the walking pattern, reflexes, and that history. I think a big thing from sort of what we touched on earlier and with what you were showing me on the computer is that subjective assessment. That's medical history is important for. So I'll just bring the camera up over towards the upper thigh. I've not marked L1 just because it's sort of upper in sort of this anterior hip region, spanning across and in ever so slightly before we go into sort of your sacral nerve patterns. But that general one, we're looking at your L2 spanning across the front, all the way across diagonally towards the medial knee pattern as such. So sort of all the way across from this area, or if we show you on this side of the camera, across that. Then L3, we're going slightly distal, slightly more lateral as well, same sort of area across into the knee. And you'll see various patterns where it's sort of cut off and right, this part goes from, let's say, here to here, and that's it. Not a big fan of that. I think dermatomes, they cross over. It's very hard to map, but like I said, it's a general idea of where they are. L4, we're looking more so on the inside. So from maybe some of the physios and students watch this, I might remember this, is L4 is indoor, so it's inwards, it's medial of the lower limb below the knee, and L5 is to the side, a bit of a rhyming pattern. We know physios love our rhyming sort of patterns from there. And then I kind of sort of split this through from sort of tibial tuberosity and then kind of go at a bit of an angle all the way down. But I go behind sort of the medial malleolus, where that's that L5 spanning all the way down, medial into sort of the dorsum of the foot, big toe, 1, 2, 3. So the first 3. Sometimes you get it into that 4th one, but mainly that's what I would go for your S1 pattern on that lateral side. So it's very interesting for me as well to piece what you were saying with all of the sort of peripheral nerves and how that links into the sort of dermatome patterns as well. And then we're also looking at the dorsum of the foot for that sort of S1, a little bit of your L5, but then, sorry, plantar of the foot. Just testing you just to see how you are.
So the neurological testing is pretty as well as the patient.
Yeah, from that end.
Question: would the average physio be able to kind of map out the dermatomes as a whole body?
I think so. Yes.
I'd
hope so. Whether again specifically or not, they would typically say, right, okay, L5 is outside of the lower limb, top of the foot, L4 on the inside. And again, this is where I'd put my hands up and say, but again, I don't really have a huge reference point for where they would be. No bony landmarks, yes, I use them a little bit, but it's because from what I've read, from what I've looked into, they overlap. So when I go through teaching with students or juniors, I will do a little bit of referencing in regards to, right, S1 here, I would probably use the lateral malleolus and say anything sort of below this area, sort of from sort of here all the way down.
So do you see patients where you think you've got a single dermatome nerve root irritation giving issues with, because obviously dermatome is skin, and then myotome as well? Are you testing for that?
Testing for both, plus reflexes, plus the general history. So yes and no. I use the dermatomes from a pattern. Right, let's say Grace has that lateral, again, I'm loving the L5 here, so the lateral sort of lower limb into the top of the foot. I'd be thinking, right, differential L5, and I could tie that into it, but I wouldn't use that as a end point. Right, it's got to be L5 because of what numbers there. I'd do myotomes as well, big toe extension, dorsiflexion, and then ruling anything else out as well. So make sure that we are doing your plantar flexions, your inversions, eversions as well from that nerve level. Does that answer that?
It does.
Yeah.
And I guess the next question is, so what? So you get that patient that's got, so Grace, if you dorsiflex your foot for me, so my guy who we were talking about, who is weak in all of the extensors, all 3 as well, I'll see people who have, it's called sometimes just a weak tibialis anterior. So that can be, an injury, or it can be, something kind of motor neuropathy going on. So what that does, if you've got a weak tib ant and you can't dorsiflex your foot, you recruit EHL and EDL.
Yes.
So that's when you get this what we call extensor substitution type of hammer-toe deformity. So I can say, all right, my guy who is weak in all 3 foot extensors, but so what? And that's what I've not had the results of the MRI back yet, and I've said to the guy, give me a tinkle back when you've had it, because I kind of want to know. I'm probably not going to be doing anything there at all.
No.
I mean, in theory, because he had a bendy big toe and he's not pushing off, distally I could fuse it to give him a straight toe that he can push off, but that's down the road a ways. But what are you going to do with that patient? You found somebody that's got, say, an L5 issue. What would you do for that patient?
Right, first and foremost, and I think I preach this all the time, is clear the red flags. Clear your caudoquiners, your infections, malignancies, potential fractures, which we said myotomes, we said dermatomes. It would be a case of, if it's something where I think, right, there's foot drop, for example, I would be referring on. I'd be referring on to a neurologist, spinal surgeon. Let's get that looked into. Let's get an MRI of the lower back, and let's get some nerve conduction tests to see if that sort of nerve is firing off properly.
So I've been,
yes,
at my level, my history of nerve conduction studies is, by the time you get quite distally into my area, mixed results. I think if you're kind of testing up here, yes, but I think sometimes when you get down here, I have a fairly low confidence that the nerve conduction studies are kind of kosher. Really.
Okay, yeah.
So I don't refer off of that very often. Maybe for post-tip, maybe. Certainly within the thought, I don't bother. But that's the thought. But I used to. It used to be that we used to teach, if you've got a tarsal tunnel syndrome, you need three things. You need a history, as in a history of somebody who's got neuralgic pain, a positive physical examination, I'm getting purpley hands now, as in you've got soreness, and then nerve conduction studies, and any two of the three would be tarsal tunnel. But I had so many misdiagnoses, I just kind of went, if I've got somebody who's got neuralgic pain and the sore there, it's tarsal tunnel.
Yes, yeah. Yeah, with what I see, where you're looking more with the myotome, the dermatome, it would be, can we treat it conservatively or does it need to be referred onwards?
Cool.
If it's referred onwards and it gets thrown back, actually, yeah, there's a, let's say, disclination, that's pressing on that sort of L5 nerve root. Is it a case where we go for conservative with physio, or is it, do they do an injection just to take off the inflammation of the nerve?
Yeah, yeah.
That injection is not going to help the disc, it's not going to help that retract or unherniate as such.
Correct.
It's going to reduce, the steroids will reduce the inflammation it puts on the nerve. So they'll still have the disc issue, but again, we know with time, the majority will probably heal by themselves. It just depends if it's failing, conservative treatment, if it's worsening, that's when they need that surgical intervention.
Certainly know within the foot, and I found through a bit of experience, because a lot of the work I've done has been with local anaesthesia, you think, okay, I've got to do a lesion, say, for instance, bottom of the foot, and you've got a lesion about here, and that would be your medial and lateral plantar nerves, so you do a tibial block. But you'll find some of the dorsal nerves will come through, and it's much more of a network rather than like that. So I'm guessing it would be the same as dermatome, you get that little bit of overlap.
Absolutely. You've got that network, that overlap from sort of the lumbosacral plexus, which within the research and some of the testing, when they've tested the same individual, same candidate multiple times, different forms of testing, which we won't go into because there's a lot to talk about there, they get different results. Yeah. They've had pain, they've had numbness, they've had pins and needles in different variations or different patterns of dermatomes, rather than the classical patterns we all see, which is really based off sort of the 30s and the late 40s research.
So Grace knows she's not driving today, is she? So because we're going to put some local anaesthetic in and we're going to see how that kind of goes.
Do I get a day off work?
Yeah, 3 days after that, yeah, rest of the week.
We're not agreeing this with Grace. Give me sign the waiver. Oh no!
I'll send you the waiver.
Oh no!
We're supposed to read and sign it. Have you got an automatic?
Yeah.
Fine. So just do it. I'm joking.
It's alright.
But that's one of my old tutors back in the day. That's what they did when they were kind of learning ankle blocks. I'm literally about 40, 50 years when pod surgery was born. Is there was a group, and they basically spent weeks injecting each other and mapping out what nerves went, and that's how they developed not only how to do an ankle block, but also they noted the kind of the variation.
And that's the same. There's two researchers from there in 2022, 23, and they mapped out on cadavers, on testing cervical, brachial plexus, and lumbosacral plexus, and they found particularly about 50% sort of variation in those nerves following a dermatome pattern when they were tested, when they were run through with the nerves. On the cadaver set, which again 50% is you're flipping a coin, aren't you?
So you take top of the foot. I said the soral nerve has got 5 different variances.
Yes.
So top of the foot, we would have most medial aspect of the superficial perineal nerve, deep perineal, back to the superficial perineal, soral. So 1, 2, 3, 4 nerves.
Yeah.
But there are, get this, 12 different variations for how those nerves innervate. So for instance, the deep perineal, sometimes it doesn't do the big toe, sometimes it doesn't do the second. Sometimes that one stops there and the saphenous comes out. So there's 12 different variances based on old studies. So I'm just going to borrow this leg again. So I did a case a few years ago, superficial perineal nerve, hemorrhage neuritis, popped some steel, didn't make it any better, so we needed a surgical decompression. So we did a little incision, found the superficial perineal nerve, and at that point it should have been coming out of the fascia from the ideal then to release and decompress the fascia. Okay. Found the nerve, but no foramen. Okay, so I went a bit proximally, and I went a bit proximally, still superficial, ended up here,
Okay.
moves camera. So the nerve came out here and went all the way down the leg,
Yeah.
and then cut the deep fascia, took away all his pain, but he ended up having that scar, which was not ideal, because if I'd known the nerve was there, I could have done
It would have been
2-inch.
Mm.
So we ended up having a 12-inch scar. So I thought, that's really unusual. So we wrote that up as a paper, and guess what we found? 100 years ago, they'd done the work on cadavers and found that sometimes it comes out here. So all of this stuff has been known forever. It's just finding these obscure texts.
That's it.
And Thames wrote it up just to say, just be aware if you've got this, then actually you can have these kind of weird variances. It's literally like 2 out of 100, but was one of the ones that I found. So you think how infrequently I see this, and then he was one of the rare ones, but he had a big long scar. Thankfully, wounds heal side to side, not end to end. Righty, what else we want to go through? So we talked about, I wanted to kind of go through dermatomes. You're just a couple of seconds in on sensory testing. So what are you going to do for sensory testing? Are you doing sharp blunts?
Yep.
Are you're doing light touch?
Light touch, pinprick is standard.
Okay. And then motor-wise?
Motor-wise, gait analysis or gait assessing the gait,
Yep.
toe walking, heel walking, and then I like to just screen a general squat just to see if there is any hitching movements.
General?
A general squat, so just sort of squat pattern, see if there's any differences there.
So the only type of squats I do? Diddly squat.
I like to do a single leg stand. Trendelenburg, if I'm seeing that.
Bellerenberg or
Trendelenburg.
Bellerenberg. So Bellerenberg was a comedian from the 80s. Again, you weren't even born then. So she was part of Russ Abbott's Madhouse.
Right.
So when we get to this point in the video, let's put a little picture of Bellerenberg in.
On
So if I'm in theatre, so Trendelenburg is when you put the head down, the feet up, if I need to do that.
Yeah.
So just my humour, I asked for Bellerenberg. Nobody laughs, except me and 2 other people over 60. So that's kind of usually people have kind of a drop in game.
Yes.
What about reflexes and then motor power? Are you somebody's going to come in? No, bonjour. I knew somebody would come in.
I know.
So are you looking at reflexes? Are you grading reflexes and you're grading muscle power?
Yes, so reflex-wise, we're looking at sort of L3, L4 for the knee jerk reflex, S1, S2 for ankle, and then also plantar reflex. So is going to be a positive Babinski. So
Have you ever seen one?
yes,
For real?
I have once. I believe, if my memory serves me correct, it was on a spinal patient, had a decompression, but they had a undiagnosed MS.
Huh.
Yeah, interesting.
Huh.
I think that was the case, but I've seen one and one only, so it is obviously quite rare.
And are you grading sort of motor powers? I know there's a couple of different scales.
So
you're going back 0, 1, 2, 3, 4, 5,
yes,
that kind of stuff.
single Oxford scale,
Yeah.
absolutely. So I look at it quite systematically. So I try to get the patient to do it themselves, that active movement, comparison left to right, and then I'll apply that pressure, and I won't go sort of straight off. So great, if you bring your left foot up towards you, I won't go straight in and I won't just push. I'll sort of grade it through. So I'll hold it through there, push, you resist me, you resist me, you resist me.
It's very difficult for women to resist it. Sorry.
I'm keeping that in.
No.
So I'll grade it through like that as well, and that's also a thing with the toe and heel walks as well. So grading that through there, but I'll start.
So you're kind of doing this, but you're thinking more cerebellum for that?
Yes,
Sure.
yeah. So again, just for that screen. So if we're going to go over to the door, I'll do it from here. So so sort of that tiptoe walk. See if they can walk from that end. How comfortable is it? Do they have that balance? Do they have that strength?
Yeah.
And then
post Tim's not gone as well, do
that's the 100%, and then that heel walk, and hopefully that can see that there. If we are thinking cerebellum, which I've not come across, I think maybe once on placement as such, we can look at sort of eyes open Romberg, start pushing.
I told you about that when I had the other way, didn't I?
Yes, you did. Yeah, and then also sort of tandem as well.
So Grace for the camera. So I had a guy. So he's an alcoholic, long-term alcoholic. So very significant peripheral neuropathy. So it's been great because we've been having some neuro talks the last few weeks. So when you've got your balance, you've got some of it coming from your brain, your cerebellum going, what's my head doing? You've then got your eyes, so you're looking around, and then you've got your peripheral system saying, this is where all my joints are. So his peripheral neuropathy was very significant. So he's lost the input then from his feet.
Mm.
We got him to close his eyes, so the only input that he's got is really from his ears, from his kind of labyrinths. So he's only got one of his three systems. So you close your eyes and you fall over.
Mm.
And if you trust the patient, if you can just give them like a little push,
Mm.
and he literally kind of had to catch you. And the thing that I test for that is I say, look, when you're having a shower, when you're in the shower, you wash your hair. How do you do that? And he said, oh, I can't do it because when I close my eyes to rinse all, I fall over. I have to sit down in the shower to wash my hair. So just because we'd lost peripheral, you lose your vision, so you lose that visual acuity for where am I, and then that's wrong, positive rhombus.
And was that from drinking alcohol?
Yeah.
Oh,
Yeah.
wow.
So it has a kind of like a predilection for nerve tissue. In fact, I use alcohol in the feet. So if I get people who've got a really bad peripheral neuritis, I inject dilute solutions of alcohol around the nerves just to kind of kill off little bits of nerve tissue. I don't do it very commonly, but that's something I do for multiple sclerosis. I do alcohol injections.
Yeah.
It's a bit out there. It's not a super common thing.
Interesting.
And so I do that. So I've been doing some neuro teaching this year. So anytime I get a neuro patient in, like Monday, my lady, or today I had my diuretic guy, I'd kind of just do a little video with patient consent, because you have to,
Mhm.
and just kind of get these little teaching bits together.
Cerebellum as well, just
Yeah.
wanted to touch on it.
Too proximal for me, eh?
Coordination. So we could do finger to nose test if we're looking, and if I find something which it's more sort of pre-planning. So let's say I see someone with they're coming through MSK wise, but actually I'm suspecting there's something else. It could be cerebella.
Okay.
Go through the assessment, have our findings and stuff. So I do sort of your, I always get this mixed up, you see, always different wording through it, but heel to shin.
Okay.
Start right at the top, so if
Yeah.
you can bring your heel up to the outside of your leg
Right,
here,
yeah.
that's it. And then can you take your heel all the way down to the bottom, lovely, and then back up to the Sarton bit. And I'd get them to do that sort of maybe 10 times, see if there's any changes, see if the speed, see if there's any abnormalities with that.
Okay.
Confirm that. Finger to nose, so get the person, pop their finger on their nose.
Yeah.
If you can try it for us, so if you pop your finger on your nose, and then
So
you
I
can
call that
touch.
past pointing when people are then doing
Yeah.
Where
Yes.
am I looking at
And
your
then
finger?
if you take your finger
Yeah.
and touch my finger, and then back to your nose, and keep doing that. So yeah, they might pass point, they might go way off, and I'll get this moving as well
Okay.
from that end. And then I'll do, is it disc diakinesis?
like ET.
Like you say.
Obviously, yeah.
You know what ET short for?
Is no.
Because he had little legs. You can keep these in one.
And then I think I always get this butchered as well. Disc diakinesis. So hands, if you can pop your hands on your laps, and then can you go palm to dorsum and do that as quickly as you can. And what we might see is in coordination, slowing down, and that could also be a case of cerebellum going as well. Danish for cerebellum. Disc diakinesis, ataxia,
Yep.
nystagmus,
Yep.
so through an oculomotor assessment,
Yeah.
you might see the nystagmus of the eyes. Where we're at eye involuntary movements, so things like maybe tremors,
Yeah.
or they're uncoordinated, that sort of stuff as well. Slurred speech,
Uh-huh.
big one, and hypotonia, so low tone.
Huh.
So nice little acronym.
So I'm going to give you a link to the one of the podcasts of these. We were just talking just before we started filming. A couple of Manchester GPs
Yeah.
who interview consultants and various kind of great good. They had a neurologist on, and they were presenting real clinical scenarios patients they see, and just this neurologist was just able to say, could be this, this, and this. It was just brilliant to listen to. Just because, well, that's what he does. You know, he's a neurologist, and it's having that link with getting to the right person.
Yeah.
You know, it's just, and for me, it's about identifying something's wrong, and then who's the right person to see,
Yeah.
which is often not me.
Just to go quickly back on the track with where I would be with my sort of up the chain stuff.
Okay.
So we said myotomes,
Okay.
dermatomes,
Yeah.
reflexes.
Yeah.
I like to look at your reflexes as your sort of generic nerve
Yeah.
jerky test, so knee, ankle, and then you've got your plantar, and then that can be your pathological. So you've got your Babinski
Yep.
on that end. I like to look at the clonus as well.
Seen
So
about two ever. I mean, I don't check
yeah,
the
so
reflexes often, so that knee was present but ankle was absent.
Okay.
So it was quite,
Yeah.
quite just as long.
So just for the viewers, I put that into dorsiflexion and a slight E version as well of the foot. And if you just relax there for us, and what I do is a nice sort of quick. I probably have the foot ankle hanging off the edge of the bed, but really quick reflexes to that. This is where we find something. What
I
we
know.
say, and so we're looking for that 5+ involuntary contractions of the foot into that dorsiflexion. I would then also, if I'm suspecting there's something up the chain, nerve-driven straight leg raise. So can I pop you down?
Yep.
That's okay.
So I'm going to think that begins with an L. Help me out. Loud.
The SERGs.
That's easy for you to say.
Yeah. The SERGs test, so straight leg test.
Yeah.
So I like to be really mean because sometimes if you just put this through, this is not really on that end with the knee. Let's okay. So distal thigh, top of the knee. Put a bit of pressure through there so it is going to stay nice and straight. I then like to put a bit of pressure on the lower limb and then just looking at patient's face and how they're going to respond, and around that 45 to 60 degree, if it's not going to stop, if it's going to stop you, if there's that tension which you can feel, that's when I'm thinking, right, there could be something on that side. Very, very rare, probably unlikely. I've not seen it, I've only read about it crossover as well. Sometimes it can cause pains on the other leg, but not too sure sort of the specificity and sensitivity of that. If I'm really mean, we could do Bragard sign, put the foot and ankle and feet into dorsiflexion. Yeah, really provokes it. Your patient won't like you after and probably won't come back. But it's a good one again just to add on.
That's almost like doing a little Vendrastic. But what I would say that is doing, tell me if I'm wrong, is obviously you're flexing the gastroc inserts proximal to the knee. So you're putting the hamstrings on the stretch.
100%.
Is that you agree?
Yes, 100%. So, but when we're looking at sort of, let's say, again, going back to that L4, L5, S1, sciatic nerve branches at the knee, all the way down, so into where that sort of tibial nerve, peroneal nerve will supply. We're putting a lot of those structures on that stretch. So again, that nerve tension, not just from sciatic, which we're doing here, but if we're bringing down, we think, okay, there's a bit there, but I want to provoke him all to see how irritable it can be. We then put gastroc, soleus, plantaris on a bit more of a stretch for that tibial nerve.
How do these points relate to acupuncture points?
Not my forte.
And is that because acupuncture doesn't work beyond placebo? Correct. It is indeed.
Interesting.
As Adam Meekins would say, theatrical placebo. Same, I'm guessing, with the chakras.
No comment. But, yes.
They also, I'm not seeing them on any anatomy textbooks.
And then I've got a video on it as well, but actually, if you're struggling to get reflex, gentracic manoeuvre,
Is it right?
pulling hands together,
Yeah.
I also like to have a distraction, jaw clench as well.
Oh, okay.
Nice desensitization, relaxing. Most of the time I find it helps, which is always good.
So we've agreed that we've still both got lots to learn, and
Yes.
if in doubt, we refer on to somebody cleverer than us. I've learned nothing, but Aidan, thank you for that. It's only because I find this stuff really complex. I love it, but I think for me, well, I love anatomy, kind of complex, because anatomy, you can see where stuff is.
Yeah.
You know it, you can learn that. But for me, the difficulty in matching neuropathology to a diagnosis and then a prognosis, I just find it difficult. And I think as any good clinician, you try and look at yourself and try and teach yourself, because that's what we're supposed to do, isn't it?
100%.
Yeah, right, yeah. I wanna
CPD.
do it. Yeah,
Yes.
yeah, because it should be self-directed. I'm still learning.
If you've got this far, thanks for watching, and thanks particularly to Aidan for doing all the editing of that. You'll find him on TikTok. He's been TikToking for a little while. He's got some great vids. Real rising star, and hope you find some of that random rambling neuro stuff of use.